Hi, so we've got another lecture on disorders of hair or hair follicles. And what I would like to present it is in the form of give this entire unit uh, a topic saying it's nothing but balding. So let's understand what balding is or what hair loss is. All right. So first of all, what we need to understand when it comes to hair loss, all right, is what kind of a hair loss it is, or alopecia. So loss of hair can be, or alopecia can be, which basically means loss of hair, can be of two types. One is scarring, and one is non-scarring. Scarring is also called as cicatricial, and non-scarring is also called as non-cicatricial, obviously. Cicatricial. Having said that, let's directly jump into the more important um, one, that's the non-scarring or the non-cicatricial. Why do I call it as the more important one? Simply because of the fact that this is something that you would see regularly or you see quite common in your relatives. So first, let's begin with um, something that's not so common. That's something that you have seen, but probably you haven't. Um, Something that you did not diagnose at that particular time, and it presents as a patchy alopecia. So it's the only one very important patchy alopecia that we have, that is alopecia areata. Now, area means patch, and alopecia means hair loss. So again, what it basically means is patchy hair loss. Now, what happens is that there is a circular patch of complete hair loss in the probably in the occipital or any other part. And why does it actually occur? Again, I told you it's alopecia areata, and that it is due to a lymphocytic peribulbar peribulbar infiltrate. Or let me write it a little better. It's due to a lymphocytic peribulbar infiltrate. Now, so what does it appear like? Supposing this is your hair follicle, let's say we take cross section, you will have lymphocytes, obviously, which are going to stay in pink, or sorry, which are going to stay in purple in the retinal stain, would appear around the bulb of or the around the bulb or the hair follicle, and therefore we say peribulba. So what does it appear as? It appears as a swarm of pea appearance, classically swarm of pea appearance. Swarm of bee appearance. Why do we need to know this? Because if you want to take a histological slide and you want to view it for diagnosis purposes, obviously you could say that it is alopecia areata. What are the other findings that you would have? Obviously, you would have on examination of the hair, you would have an exclamation mark hair. What do you mean by exclamation mark hair? Well, exclamation mark is basically a mark which is like this. So if when so what the pathologist or the dermatologist did was that they related it to something like this, an inverted cone. So when your hair shaft, let's say, is like an inverted cone, that basically means an exclamation mark, and that is again something called as alopecia areata. And another very important, this is your first sign, swarming of the appearance, and your third sign is going to be something as which we've seen in lichen planus as well. But obviously here there is geometrical pitting. There's pitting of the nail plate. So again, something to keep in mind is alopecia areata. Now, what are we gonna treat it with? Obviously, you need to know the treatment, and for the treatment, obviously, you need to understand that you gotta use steroids, and we cannot just give topical. What we need to do is that we need to do an intralesional steroid, or we need to give a peribulbar steroid to prevent the lymphoid aggregation, correct? And um, aggregation. Now, apart from that, another disorder that we should really study is something called as a trichotillomania. Now, I would like you to understand this disorder. Tricho means hair, shaft or hair, and mania means mania. Mania basically means maniac or mania, a disease episode. So what actually occurs is that there is an OCD patient who comes to you who has whose relatives of complain of plucking of hair, of plucking hair, plucking hair. So you need to diagnose this patient with a trichotillomania, and obviously you will give as a treatment you would give him lithium or antipsychotics, psychotics, depending on what kind of a cycler is he, rapid cycler, or is he bipolar, is he just a maniac patient, depending on completely upon that. You would give that. But obviously, first of all, what you need to, and let's say if you do not know if that patient is an OCD patient or not, so how would you want to know that he's plucking his hair? Because there would be perifollicular hemorrhages. So if there is a perifollicular hemorrhage, right? So um, I've said that the follicle is actually in the subcutaneous layer where there is a lot of blood. So let's say this is your dermis, so it could be your dermis, and this is your subcutaneous layer, and then obviously your epidermis, whatever. But if it's in the subcutaneous layer and if you pull it, obviously there's going to be perifollicular hemorrhage, correct? So for that reason, all the way the blood supply is all up here. So for that reason, um, if there is plucking of hair, which is seen in trichotillomania, there's going to be a certain amount of bleeding, and obviously the pattern is not going to be a particular pattern, and that's why it's going to be patchy again within the patch. So there's going to be some loss of hair. There's somewhere there's not going to be loss of hair. Simple as that. Also, another very important disorder is Tinea capitis. Now, tinea capitis, you would be wondering, why is it a non-scarring when it's fungi? Actually, it could be scarring as well as non-scarring. So, if I have to, it could be scarring or it could be non-scarring. Now, uh, if I'm saying it's non-scarring, that I essentially mean that there are no um, that it is reversible if it's non-scarring, and if it is non-scarring, and what I also mean is that the hair follicle is preserved and there is less inflammation compared to when it's scarring. So non-scarring can be of two types. One is your endothrix, one is your exothrix. So I'm going to write endo, and here you're going to have exo. So let me just endothrix and exothrix. So endothrix is going to be black, and exo is going to be gray. Gray shaft, black shaft, black scalp, gray shaft. Let me just write it down. All right, not to be racist or anything, but that's it. And if you want to know, you could know that the causative agents. But what I'm saying is that tinea capitis could be any one of these. And again, if you want to treat it, you want to go for something as griseosulfan, and and actually you could also go with terbinafine. But now this is quite, there's a lot of resistance to this drug. So you want to keep that in mind that a lot of resistance is definitely seen to terbinafine. Obviously, we're going to make a video on antifungus too someday. But yes, terbinafine is also very important. And now let's come, as an important drug, now let's come into secondary syphilis. Now, secondary syphilis is obviously we've seen a lot of disorders that have occurred with syphilis. And, that's one hell of a disease, syphilis that's itself in medicine, it could go for pages and pages. But what's more important is that right now, what we are talking about is that you want to remember that there's going to be a moth-eaten appearance. All right. There's going to be moth-eaten appearance of the scalp, and about that, I guess that is about it. That it's a moth-eaten appearance. Now, um, why does that occur? Obviously, because of treponema pallidum. And if you want to do a test, you could do your uh, VDRL, where is research laboratory uh, test, antibody, antigen fluorescence test, FAAPs, which is better than BDRL, obviously. Um, you could do that, and then if you want to treat, you could obviously go with penicillin, depending on what that stage is. If it's a primary, secondary, tertiary, you could obviously have to give IM, IM, IV, IM three times in a once in 3 times in a month, 3 times or once every week, and then IV you just need to keep it if it's a tertiary involvement. Uh, that about being it. And now let's talk about another very important disorder. Uh, so so even secondary syphilis, when it gives a moth-eaten appearance, what I mean is that it's obviously again a patchy. So when I'm talking about a patchy disorder, let me just give it to you completely as patchy. Patchy alopecia. I'm first going to talk about, let's say, secondary syphilis. Let's go reverse. Secondary syphilis. Next, I'm going to say it's tinea cavidis, and in that I would say endo and obviously exotrix, and apart from that, let's say you have a secondary syphilis, you have tinea cavidis, endo, and exotrix. Uh, what else? What else? Let me say. Um, okay, yeah, very important. Alopecia areata, the most important that we've seen. All right, and the psychomaniac condition, trichotillomania, is another very important disorder when it comes to patchy alopecia. Now let's talk about diffuse alopecia. Diffuse means there's no particular pattern. Is there a particular pattern? No, diffuse means it's all around the scalp. So therefore, in diffuse alopecia, there's just one group. There's just one group which we call as effluvium. Effluvium. And effluvium can be of two types actually. And I'm going to write about it aggressively: androgenic effluvium and telogenic effluvium. Telogenic. Now let me tell you about androgenic. Androgenic basically is nothing to do with testosterone. Obviously, that concept is incorrect. Incorrect. Telogenic is something to do with stress. So what is androgenic something to do with? Something to do with chemotherapy. Now, because of chemotherapy, what happens is that the androgenic, sorry, not the androgenic, my bad, the anogenic phase, and I have completely messed this up. Actually, this is um, this is anogenic effluvium and uh, chemotherapy. So obviously you could make a mistake as well, or you might not. I hope. Chemotherapy is the result of slowing or decreasing decreasing anogenic phase. So when the anogenic phase is gone for, let's say, for 3 to 4 weeks, post 3 to 4 weeks, this happens, and your hair shaft has gone into this um, slowed, retarded anagen, and eventually you just have hair loss. But what about the telogenic phase? The telogenic, let's say you have stress, So what do you have? So what happens is that your hair is fine in the anagen. It's fine in the anagen. So let me just give you a highlights about what I'm talking about. Well, your hair is supposed to be in an anagenic phase, then it goes in a more of a catagenic phase, and some of it, 1%. All right, and this is your, let's say, your 86%, and then it goes in your telogenic phase. Now, the reason is these different phases is basically the growth cycle. Now, anagen is where you're just growing, and it's going to be for 3 years, whereas androgen is where you're like, where probably there is certain amount of destruction, and it's just for like 3 weeks. So let's say your hair grew, anagen comes, it's like, okay, no, you need to destroy a little, let's say you need to take away some protein, and then telogenic is in the rest phase, which is for 3 months, and this is going to be for 3 weeks, your catechin phase. Now, what I'm saying is that because of stress, the hair enters prematurely, prematurely in a telogenic phase. Now, because of that, like your thelogenic phase is for 3 months, correct? So, more and more of androgenic hair is going to enter your 3 months phase of telogen, and post that, hair loss is going to occur anyways. So, if I'm saying if there is a stress, let's say there is a stress, let's say in 2019, by 2020, you would have a lot of hair loss. You would have a lot of hair loss because of the fact that in 3 months it would enter telogen, and not in 3 months, probably whenever, but for 3 months it would be in the telogen phase, after which it would start shedding. So that's the reason why uh, stress can cause certain amount of hair loss. Now coming back to pattern type. Okay, so that was the diffuse type. Diffuse just had a clue. Now, when coming to pattern baldness or pattern alopecia, there are two things that strike us really. It's something that just cannot get rid of it. So one is actually, there's only one thing that actually hits you that hard. Obviously, the other one pattern is just androgenic alopecia, and we've spoken about this. We know so many people, especially as men, we all know about this androgenic alopecia. We all know about it. The thing is, let's say you have a lot of testosterone, and that testosterone gets converted to dihydrotestosterone. So, because of this dihydrotestosterone, there's an enzyme. Uh, which converts this pi-alpha reductase is the one that converts um, this testosterone into um, dihydrotestosterone. So you want to remember that the culprit of this is your 5-alpha reductase. But what does this dihydrotestosterone actually do? DHT, what it does is that it shortens. All right, it shortens the anagen phase. It makes the anagen phase less than 3 years. And what it also does is that it also, very importantly, it makes miniature hair follicle. So now your hair follicles are basically thin and small. So because of that, your hair is thin and small, and the density has been reduced severely. Now, what does the pattern baldness basically mean? Let's say this is your scalp. Obviously, you would have a receding hairline, and you would have a vertex. All right. So this is exactly how your hair would be, wouldn't it? Look at that! Look at that! Look at that! Oh, cool. So this is exactly how your hair would be. A lot of our fathers, grandfathers would probably have it. Um, and this is your pattern bonus. Obviously, if you want to grade it, you have a grading system given by the name of Hamilton Norwood. Hamilton is a very big watch company. Hamilton Hamilton is a watch company that makes beautiful automatic watches for men. Now that because of that, you could remember Hamilton Warwood. Okay, and in okay, so you'll be wondering, is it only in males? All right, no, it's also in females. In females, what happens is that androgen could increase for various reasons. We do not want to get into that, steroids, whatever. Just being it. So what would happen in a female is that, let's say this is your scalp, or let me just make a female scalp more, you know, female. All right, that's her scalp. What's going to happen is that you wouldn't have hair loss out here at the center. What you would have is you would have hair loss in this. You wouldn't have hair loss at the forehead. Rather, you would have a hair loss over the central portion of the scalp. That means her hair are going to be perfectly normal from this side, except when it comes to the central scalp area. Now, that's something that we actually know to know because the frontal hairline is completely maintained in a female. And for a female, you have a Ludwig grading system, that about being it. Now, if you want to treat, all right, very important, and this is why most of the people are watching this video, is that you have to have minoxidil, a vasodilator. What it basically does that it gives your hair follicle more nutrients, and because of that, your energy is increased. All right, and also the size of the follicle is increased. Size of follicle is increased. Second, what do you want to give? You want to give a finasteride. What is finasteride? Obviously, most of us also know that it's a 5-alpha reductase inhibitor. Because of that, DHT is lessened. Because of that, DHT is lessened. And because of DHT being lessened, your anagen is increased and also your follicle size is increased. Whereas do you want to give a 5-alpha reductase inhibitor, you also want to give it in a BPH, benign prostatic hyperplasia. Again, BHP is responsible for the hypertrophy of the prostate. Obviously, you want to also give, there's another form of treatment which is called as a PRP, plasma rich protein, very famous these days. And fourth is you want to do a hair transplant in case of complete hair loss. Obviously, you do not want to reach that case, so better diagnose it early. Another very important disorder that can actually cause, you know, um, alopecia. And what I mean is that it could does not have a particular pattern. It is not pattern. It is not diffuse, nor it is patchy. It's just non-cicatricial or non-scarring alopecia is SLE. SLE can also cause cicatricial, and you also have thyroid dysfunctions that could lead to that. But that's very important about being it. Now, when I'm talking about scarring alopecia, scarring, and that means there are certain amount of scars formed. So uh, it's less it's rather irreversible, and moreover scaling plus pruritus is seen. And um the hair shaft? If I talk about uh, the non-scarring, obviously your hair shaft is also lost, or the hair follicle is lost. Now, I just want to name a few disorders where it can be seen. Yeah, it could be seen in lichen planus. Lichen planus is uh, fabulous formis disorder, again, an inflammatory disorder of thickening of the skin. And there you see blue gray hair. All right. Second is going to be, um, you could have it in discoid lupus erythematosus, LE, or you could have disc-like SLE. But I told you SLE could be non-cicatricial as well, or it could be also in linear morphia. Linear morphia is thickening of the skin, and therefore, again, you would see something like that. So two, three, four. All right, all right, all right. So apart from that, yes, very important. Again, I told you tinea capitis could also be scarring type. It could be cicatricial. So tinea capitis, if it is the scarring variety, it could be of two types. It could be a Favis or it could be a carry-on. So I would write a 5A, and a 5B would be a carry-on. A Favis would be like Trichophyton Schonli, and your carry-on would be by certain phytophytons, which you do not need to remember because of the fact that they are animal zoonotic trichophytons. I don't know, probably even I don't remember it, so I haven't gotten into the details of it. But definitely, here you would have a yellow cup on the scalp, and here you would have a boggy scalp with swelling, and you know you would also have some amount of lymphadenopathy, and in both cases, you would um, treat by giving Glyciosulfan. All right, that about being it, and that's how tinea could cause scarring. And the sixth one is going to be an inflammatory disease called as folliculitis de decabans, and seventh is dissecting cellulitis of scalp, and eighth is your pseudo palad of rock. Uh, Pseudopelade of rock is something like a snowfoot in your scalp. So if let's say this is your scalp and this is your scalp, and you would have just areas like just lost areas of hair, and it appears as if you've just took your foot and you've actually stamped on it. And when I want to do an histology, obviously, let's say this is your follicle, there's a lot of fibrosis that's around. So perifollicular fibrosis is also seen. So pseudopelade of rock, dissecting cellulitis of scalp, folliculitis decalvans, tinea, linear morphia, which is basically thickening of the skin, disc-like SLE, discoid lupus erythematosus, lichen planus, and all of these are scarring uh, alopecia. That about bringing it. Thank you.